Welcome to this presentation on leading your department from the bedside to the director. My name is Gary Kaufman, and I'm a career-long AERC member and delighted to be able to provide this presentation to you today. My financial relationships and fiduciary relationships are listed here. Most of all, I'm proud to be an AERC member, and I hope that you are as well. Here are my disclosures. Proceeds from an honorarium will be distributed as follows. And what we like to say is clothes and food for the body, hope for the soul. Now, our learning objectives today are to appreciate the difference between managing and leading. And yes, there's overlap. Secondly, understand what the organization needs from you as a leader, whether you're a leader at the bedside, an educator, a faculty, an RT navigator, director, manager, all those are leaders. And thirdly, how do we apply the leadership skills and competencies to demonstrate your value? So what is a leader? You could look on the web and you could find hundreds, maybe thousands of definitions. I don't think anyone is right or wrong. I like this one, and I'm going to read it, and then I'll take a minute to highlight some of the key words here. It's the skill of influencing people to enthusiastically work toward goals that are identified as being for the common good, and character that inspires confidence. So think of the key words. It's a skill. People are not born leaders, despite what some of us may think. It's a skill to influence people to work together for a common good, common goal. And that leader, to be an excellent leader, should have character that inspires confidence. So, busy slide. What's on the executive plates? Interoperability, clinical analytics, patient experience, AI, value reimbursement. You can look at the list. Certainly, that's why our executives spend 12, 14, 16-hour days. But what's not on this list? How to handle excess profits. That may sound laughable, but 30, 40 years ago, that was more of an issue for hospitals where they're in a fee-for-service world, where the more that we did as RTs, nurses, physicians, and others, the greater the reimbursement for hospitals. But that had long passed. In fact, I read just a couple months ago that more hospitals than not are operating in the red for Medicare and Medicaid reimbursement. Doesn't mean that they're operating in the red overall because there's other forms of income. But if you take a look at this list and just remember what's not on it is how to deal with excess profits. Now, this list looks at what I call, what is our historical operational focus and what's the focus today? And this is certainly not an inclusive list. There are certainly other things that we're thinking about, but let's just take a look at some of these. In the past, it was acute care, the hospital. When we said go on to work, where'd we go? 99% of us went to the hospital. Far lower percent today because we're working in subacute and post-acute ambulatory environments. We weren't as aware of the cost. Why? Because we could pass that cost along to the reimbursement system. We're focused on providers, meaning physicians and extenders and others, and it was really focused on inpatient, less so outpatient. We had silos, we call them departments, and sometimes we work to optimize one and not the system. Frequently, this comes up with medications where a pharmacy may buy a medication or respiratory therapy buys a medication, and if it's in your budget, you're more likely to be looking at it. The patient wasn't as much an active member. We provided services to the patient, not engaged with the patient. Mentioned before, fee-for-service, really based on volume. We had terms like midnight census that we counted every night. Are the beds filled or almost filled? And 40 years ago, there were over 6,000 hospitals, if I remember the list correctly. Now, with mergers and acquisitions, it's getting rarer to see a standalone hospital. So what's the focus today? Chronic disease management, cost, efficiency, productivity. Consumer focus. We have various metrics to gauge how we care for the patient in their eyes, not ours. We've moved away from discharge as a term to transition, transitioning that patient to become a person in their next level of care, whether that be skilled nursing, an LTAC, an ALF, or home care, or maybe home with health nursing. Multidisciplinary teams. Yes, we've always had teamwork, but even more so today, the teams that we have are focused on that continuum of care, the efficiency of a process, and making sure that we're not optimizing one service to the detriment of another. EBM, or evidence-based medicine, and best practice. If we're not practicing to the top of our license and not employing protocols that are validated, clinical practice guidelines, and pathways that integrate the best science, we're not keeping up with what we should be doing today. Pay per performance, not a term I would have heard 20 years ago, but because the Patient Protection and Affordable Care Act, where hospitals are paid in part for their performance in terms of safety and quality. Value-based incentives and integrated delivery networks. If you're not familiar with that acronym, IDN, I'd suggest that you add that to your common terminology. Who can be a leader? Let's get this straight. Everyone, simply everyone, whether you're a director, a manager, a team lead, night shift therapist, that agency therapist that works the weekend option, can be, should be a leader in what they do. So let's look at some examples of clinical leadership. What can you do? Well, you can lead from the bedside. So what are some things that you can do? Read the literature. Respiratory Care is our AERC science journal. There are other journals. There's other information on the web. There's other peer-reviewed journals and non-peer review. But make sure when you look at each of those that you're thinking about what is the evidence, because that's what you're going to apply to deliver high quality, safe, and cost-effective care. It's important that we integrate clinical practice guidelines into our clinical pathways and our RT-directed patient care protocols. That's the science. You don't need to be a director, don't need to be a manager, don't need to be a COO. Frontline therapists are the ones that I think are actually the best prepared, best educated, and really the most impactful to make sure we're delivering the highest level of care that we can. Another thing we can do from the bedside is educate us, both students, new employees, physicians, nurses, and pharmacists. So don't stand in the back of the line and say, well, someone else will do that. You can do that. You, the night shift therapist, the team lead, the navigator, you are expertly prepared to talk about best practices in respiratory therapy, because that's who we are. Precept RT students, as I'm recording this, we're seeing a nudge in our enrollment in RT programs, thanks to AERC and BRC and co-work programs. And also, people are learning about us, not only through the pandemic, we run events, as that logo said, but we've gotten more visibility and we're seeing an uptick in our enrollment. Now, having said that, we still need to have all our schools filled to the brim, because we're going to need everyone to replace those of us in the years ahead who are retiring. Actively participate in patient rounds. ICU rounds, do you stand in the back and wait till your name is called, hey, respiratory, or are you at the front of the line and saying, here's my respiratory care plan for this patient. This is my assessment, this is my recommendation, this is what I did. There's where you demonstrate your value. So let's look at some examples from the literature. This was published over 30 years ago. And I think it's one of the things that we need to think about today. How do you lead from the bedside? Well, look at this study showed the percent of correct MDI use by physicians, 43 to 65, nurses 4 to 83, RTs 85 to 100. When your patient is being trained on their maintenance inhaler, could be a DPI, SMI, that may be different than what they're getting in the hospital because they get an acute drug. Who's best prepared to do that? The numbers haven't changed. The numbers aren't going to change. We are the best educated and competency tested healthcare professional to deliver respiratory care and educate patients and significant others how to use their devices in the home. It's a great article, and I mentioned it in another presentation. It's called Device Switch Failure. If you just Google it, you come up with it. But patients who are on a neb who go home an inhaler, or vice versa, when the devices are switched, they have a higher increase in the 30-day readmissions. So what do we need to do? Employ the AERC Safe and Effective Staffing Guide, validated procedure times that will give you the time credit to spend that time with the patient. It's not about charging for the procedure. It hasn't been, isn't, not going to be. It's about providing high-level care that ends up with patients staying in the home where they want to be, not coming back to the hospital inappropriately. You'll hear me say protocols and pathways in this presentation. In fact, most everyone I do. Protocols, RT-driven patient care protocols, are how we apply the science of respiratory care. And here's what we get. Enhanced quality, aligned resources, actually improves patient satisfaction, reduce cost by eliminating waste. And one study done probably 10, 12 years ago now showed that staff satisfaction rose when that department implemented protocols. So in the times we are now, where we have more vacancies than we would like, along with nurses and physicians and others, and the cost of recruiting, the cost of training new staff, why don't we do those things that improve staff satisfaction and engagement and retention in the job? Protocols are one tool to do that. So I want you to look at the dates on this just for a second. What, 30, 40 years ago? 40 years ago, we had evidence that showed that there was a positive impact when we utilized protocols. Rick Ford and his team in California showed a 60% reduction in nebulizer treatments and chest physiotherapy. 60% reduction. Shapiro and team in that same year showed a 61% reduction in bronchial hygiene. Zebrock and a team in 1986, a decade before that, showed a 58% reduction in aerosol medication treatments, 92% in IPPB. And for some of you listening to this, you may not know what IPPB is, but that was the precursor to a lot of the breathing treatments we do now with nebulizers and inhalers. 55% decrease in incentive spirometry, 57% decrease in ultrasonic nebulizer, with no adverse outcomes. And the last example was Mary Hart, published in 1989. What her team found is they reduced bronchopulmonary hygiene treatments from 48 to 11%. Look at that. Better quality. Providing a service that isn't needed will increase safety concerns, increase RT labor that we don't have enough of today and typically don't. Anyone listening to this that has time in their hands, please call me. I've got projects you can help with. I don't know a department that is 100% staffed all the time. So protocols are how we lead from the bedside, apply evidence-based medicine in a cost-effective manner. Now, how do you get the attention of leadership? They don't, your executive team, great knowledge for what they are, but for the most part, they're not clinicians, or the vast majority are not clinicians. If they're a doctor, a nurse, or therapist, good for you, but many are not. They do respond to, we can save you money if we do X, Y, and Z. Protocols are one of those. So how do we show them, or how do we get their attention? Show them you can save money while you're improving care. I won't go through these verbatim, but Look at the dollar savings, $250,000, 1988, $206 per patient, times how many patients did you have? 10,000 patients? 4,000 saved there, 81,000, Doug Orens and team in 1993, and Rick Ford published in 1994, $150,000 saved. So if you do the math, choose any of these that you want. Where are you going to find the money to hire a respiratory therapist to be a navigator, disease state manager, to increase your pulmonary rehab program, put a therapist in home, all of which those roles save money, in some cases make money, improve the safety and quality and patient experience. Here's where the money goes. As they say, show me the money, here's the money. So there are challenges, and I want to just spend a minute or two on this because this is where a lot of us get hung up, leading from the bedside. Physician resistance. Physicians are certainly the highest educated, and they're good people. Some of them believe, some of them like even to write the orders. Now, why would they want to do that? Well, if I write it, then I know what the patient's getting. I'm a physician. I've gone to school for 12 to 16 years. I know best, and perhaps they do. Or the one that I find is that if I write for the protocol, I don't really know what's going on with the patient. So we need to think about that because we can make that the easy button for them in the EMR. The second, and I heard this from a medical director just a few weeks ago, I'm helping an RT director implement protocols. And the new medical director of respiratory care, really nice individual, said, I know, but I don't know if all RTs know how to do this. So we need to train them. And we can do that because we were trained at one time to do X. We can certainly be trained to do Y. Third one, I think, is one when you're talking about therapists, clinical therapists at the bedside. Yes, I listened to this lecture, and Gary's last two slides showed that we can save money by reducing treatments. I may not have a job. And the answer might very well be, that's correct. You may not be needed on night shift because you've employed a better nebulizer through a protocol and you reduce the number of PRN treatments. That's not good if I'm the night shift therapist. Say, hey, I'm the low man in totem pole. I'm going to lose my job. Well, maybe we don't have a point of rehab program, and now we do. Maybe we need an RT navigator, but the director hasn't been able to get the funding for it. Now we do. So we cut waste and paste that into value. The fourth is misuse, and maybe misunderstanding is actually a better word, but the concern, particularly from physicians, are that I hear are, well, maybe they'll reduce the number of treatments or types of modalities, and there's going to be a bad outcome. And I'm the one whose name is on the bottom line for that, which is true. We need to make sure that we're adhering to that, and that's the next bullet point. If we come up with a care plan on Monday morning for Q2 albuterol for 3, and then Q4, maybe by 3 days later, their TID and PRN, we need to make sure that we're using the patient assessment tool and the physician is aware of that. The next point is protocols not based on best available science. Not that our services are all tested and validated at a randomized control trial level, because they're not. But we're using the best available science that we have to do that, and we need to communicate that to physicians. The last one is the chair of the AERC Safe and Effective Staffing Guide Committee. I get these all the time. I get it, Gary, but we don't have the time. We don't get credit for our patient assessment. Well, yes, you can. In that resource you can get from the AERC, there is an initial patient assessment and subsequent patient assessment time. There's minutes there to do the initial and subsequent, again, according to your department policy. Anyone who needs help with using that resource, feel free to contact me at your convenience. Question everything. And why do I say that? I don't say that to be a negative Ned or negative Nelly, but we have to question everything we do with the point is, am I providing the best care for the patients we serve? Am I doing too much? Am I not doing enough? Am I using a modality that's not clinically validated, which there's no evidence that it works? So here's an example. This is a paper published in Respiratory Care about 3 years ago by Dr. Bruce Rubin and Jeff Haynes. And this was a paper based upon the presentation that Dr. Rubin gave at the AERC Congress the preceding fall, the Kittredge lecture. And this list, I'm not going to read the whole list, but I'll give some examples. This is a list of interventions that we thought at one time were evidence-based. And the answer is, over time and research, they're not. IPPB is better delivering aerosol medications than a nebulizer. No, it isn't. For those patients that can take a deep breath. There's really no need to push the gas in if the patient can do that for us. Normoxy and eucapnia at all costs. I remember as a student, we've got to blow down that PCO2 to 45 and keep that PO2 at 95. That's what we did. We had no evidence for it, but that's what many of us thought. Evidence came out, no. Keeping the PCO2 at 45 when their normal is 55 or maybe 60 or 65 has not been shown to increase positive outcomes. Sedating the patient during mechanical ventilation. We sedate them, they'll get rested and they'll get off the ventilator sooner. They just didn't. Blow by aerosol and crying during aerosol treatments. I can remember my student days being instructed, don't worry if the child starts to cry. They're going to be gulping big breaths, and that's going to get the medication in better. So I made a note of that, and it was on the test. Nothing could be farther from the truth. If they're crying and screaming, they're not going to get the medication. Levoalbuterol is more effective and has fewer side effects than racemic albuterol. Not so, according to Bruce Rubin, and he had the evidence to back it up. And there's a couple of points here about all that wheezes is asthma. No, it's not. And the last one is use of percent of predicted to classify pulmonary function data. Used it for years. I was taught in school decades ago, and I read an article not that many years ago. It said, nope, that's not how it works. So we need to stay current, read the literature so that we can practice evidence-based care at the highest level of evidence that we have. Again, to restate, it may not be randomized controlled trial level, but it's the best available evidence that we have. So what are some characteristics of bedside leaders? Here's some. We're able to demonstrate our knowledge, respected by physicians, nurses, and our peers, team-oriented, we have confidence. We continually practice, and we understand culture, which is a big factor that a lot of times we don't talk about, the roles and positions. So what's it mean to be respected by a physician? When you're in ICU rounds and you have prepared that 30-second, not 2-minute, that 30-second report, your patient assessment, your plan, and the patient response, 30 seconds. If you're in the back of the crowd, behind all the cows and wows and short coats and white coats and don't speak up, you won't be respected. You want to be visualized. Come prepared. Assess the patient to our plan of care. I made the adjustments in these ventilator settings. I drew a blood gas. There was a positive response. Here's my plan toward working with the RN to liberate the ventilator from that patient. Would that take 20 seconds? Yeah, I throw in the numbers there, certainly. Confidence. I'll probably repeat this, but there's 2 C's that are important: competence and confidence. If you know what you're doing, but it doesn't look like it, you're not going to make the case. If you stammer and hesitate and haven't prepared that 30-second or a 1-hour lecture, whatever it might be, if you don't look the part, you're not going to get the part, and you will be devalued, quite frankly, in the eyes of the individuals who don't see you as having competence and confidence. Practice. We need to continually improve our skills and knowledge. We learned decades ago that IPBB is not more effective in delivering medications than patients who can take a deep breath and cough. We learned that years ago, but it took us probably 2 decades to stop using those tan machines in those green boxes. Those of you who are around know what I'm referring to, because we didn't pay attention. We didn't increase our knowledge. And the last, we need to understand what the culture is in a department, in a hospital, in your unit, in your shift, and how that's different. I started out my career working night shift at Academic Medical Center, one night shift. Just a wonderful shift. We got along famously. The nurses and the attendings were the third-year fellows and the respiratory therapists. We knew each other and was a well-oiled machine. The culture on those night shifts was very different than day shift. One, we had no one looking over our shoulder, to be honest. And we didn't have the meetings and things that you have in day shift. I'm not saying nights is better than days, vice versa. I'm just saying the culture is very different, and the roles are very different, and the positions are very different. And we need to understand that. So I talked about leading from the bedside. What else can I do in addition to providing great patient care based upon the best available evidence? One of them is Journal Club. If you got one, great. If you got one, are you participating? Or are you leaving that to your department head, or maybe an educator, or maybe a faculty from a local RT program? Everyone, and I do mean everyone, should play an active role. So what do we get out of Journal Club? We educate ourselves. Journal article a month. You download it from Respiratory Care, you print it, put up on the corkboard, or you email it to the staff in the department, and you say, each month we're going to do one, and here's the sign-up sheet. Sally's always first, Bob's always last, and have them give a 5-minute presentation of the highlights of that, and then 10 minutes of discussion. I don't know anybody has an extra hour. I don't know anybody has an extra 30 minutes, but this can be done in 15 minutes because we've already read the article. We might even scribbled some notes on that hard copy on the corkboard or whiteboard. Staff engagement. It's difficult to get and keep staff today. And I think that's going to be the case for the next few years because we have a lot of retirees, and the boomers, of which I'm one, is the largest cohort in our profession, and they're retiring. So how do we recruit? How do we retain? One is Journal Club. It might be the deciding factor between someone staying or leaving. Hey, they've got a Journal Club, they've got a clinical ladder, they use protocols at the hospital down the road. See, it's been nice. But if you use protocols, have a clinical ladder, have other celebratory events, and share the energy and passion you have, maybe those are the small things that are really the big things. Upper CEUs. Yes, it's extra work, but the AERC provides a simple online form where you submit for CRCEs, or what I call CEUs. Maybe that attracts staff. Maybe that retains staff. So just like this program here, you're getting a CEU for a modest amount of money. In your department, you can do it. And not every department, but it might be that deciding factor. So you know what? My department provides half my CEUs for my license. I'm not going to get that across town. Engage other professionals, both clinical and administrative, and support. So maybe that Journal Club is about understanding reimbursement. Why not invite the Vice President of Finance to talk about a very brief 100 level, I would say, Journal Club article? Here's how hospitals get reimbursed. 2 things happen. One, the VP of Finance, as she finds out where the department is, sees a room full of people for 15 minutes, understands that 15 minutes is all we have because we're busy as heck providing great quality care, and they see our faces and we're attentive. What have you done? You increase the visibility and value in the eyes of that VP of Finance. One is engage RT students or other trainees. I don't know if you work in a department that serves as a clinical affiliate, but if not, you may want to consider that, talk to your local RT school. Secondly, if you have students rotating through your department and you treat them well, and I mean that in a way that you all mean, and you show them the benefits of working in your department, maybe they come to work for you, not the hospital down the road. What other things can we do? Most of us are not trained research scientists and never going to be. That doesn't mean we can't study stuff and make improvement. I call that quality assurance, performance improvement, and clinical research at the high end. So why would we do this? It demonstrates our knowledge. It builds teamwork based upon a common good, common goal. Remember that definition from leadership, the first slide? It builds teamwork toward a common goal. Contribute to improve clinical performance. We used to use this device. We moved to a more effective device. And look at this, the number of breathing treatments per patient has decreased. Here are the dollars saved, here are the labor saved. So invite your vice president of finance, invite your COO, invite your CEO or president, and invite your director of quality assurance or performance improvement, and show them what the team did. Maybe a purely respiratory therapy team, but most likely it's a therapist, and a nurse, a physician, maybe PT. Show them what the team has accomplished: safety, quality, financial performance, cost effectiveness, and demonstrate teamwork. Improve financial performance. I mentioned before, one of my colleagues I met many years ago switched from an ineffective nebulizer to a clinically effective nebulizer, saved tons of RT time because the patients didn't need as many breathing treatments. And they actually decreased the length of stay. That was Christiana Health System, by the way. Staff engagement, retention, it's probably on the fourth or fifth slide. Tough to get them, tough to keep them. Why not engage us together to build that camaraderie, to improve performance and improve retention and engagement? Lastly, you might do what is a simple quality assurance improvement project. It could lead for you to submit that as an abstract to the AERC. It may lead to a full research that ends up being an article that you can submit. If it doesn't lead to the article, it can lead to the abstract. And I know to the states I've lived in, they have abstract presentations at their annual meeting. And maybe that's one way that you can increase the visibility of your department at that annual meeting. And maybe a student comes up to you and say, hey, I really like what I heard about your teamwork. I was thinking about working for the hospital down the road, but I don't see them here. I don't see them as engaged. I don't see them talking about teamwork and engagement and respiratory therapy visibility. I see no reason why not to do this. There are so many top 8, top 12, top 13, top 14 lists. I pared them down to what I think is a concise list of these are the expectations of leaders. This is an important list. They are team player, enthusiastic, even when it's a crappy day, enthusiastic, help others. They like what they do, share the credit, and maybe more importantly, accept the blame. Positive and constructive, good listener, keep their cool, integrity, high integrity. They're reliable and they're loyal. Now, loyal doesn't mean you have to like everything your organization does, but it does mean that if you want to be seen to be a leader and you have criticisms of a policy or procedure, or maybe the pay and performance system, you go through the channels. You don't put on Facebook, our pay here is terrible. You don't talk with friends. If you don't like it and it can't be changed, then we might have to accept we move down the road. But loyalty is something that doesn't mean you blindly accept everything that goes on. It means we're professionals and we're leaders and we know the right way to go about suggesting change. And if it comes, great, share the credit. If it doesn't come about, we got to keep our cool. We got to continue to work together. So here's another list. And you'll notice there's a lot of overlap here. Honesty and integrity. Well, you wouldn't think, why do we even have this on the list, Gary? We're honest, we have high integrity. But does everyone see it that way? Confidence. Remember I said competence, knowledge, skills, and confidence. Inspire others. Commitment and passion. Excellent communicator. I heard the phrase early in my career, physician asked a respiratory therapist, what do you recommend? And this is a quote. He don't need these treatments. I was new to the department and I made a note. I didn't talk to the doc, I didn't talk to the therapist, but I made a note that that physician who has spent 10, 12, 14 years in training, when they hear the phrase, he don't need those treatments, maybe the patient didn't. What should have been the case was I assessed the patient and the order that we had for Q4, it was that long ago, it was bronchosol. Q4, the patient no longer requires that. What I recommend is BID and PRN, and I'll check in on each shift. What a difference between, he don't need those treatments. Not even correct English, by the way, to patient assessment, recommendation, able to make decisions, accountable. Hey, I messed up. I said numerous times at one point in time, I had short white lab coat, had bronchosol in one pocket and another medication in the other pocket. Medication's so old, I won't even mention it, but just there was an older medication, Isopral. And I messed up. I went into a semi-private room and I'll say Bob and Ted. I gave Bob the Isopral and Ted the bronchosol. And again, I was within arm's reach of both, and they had long-standing, I could assess them. I wouldn't do that, by the way, if they were in two different rooms, but this was a different scenario. As soon as I did, I went to put the Isopral back in my pocket and it clinked because I had given them the wrong drug. So I stopped it. I told the patient, and each of them had 8 or 10 or 12 puffs, so it wasn't a lot, but I still messed up. I went to the nursing station and I said, I messed up. She said, just document it. Make sure there's no patient harm. I'll be in a minute or two just to kind of double check from a nursing perspective. And what did that nurse think about me? And I tell the story, I don't tell stories about me often, but when I mess up, they're usually pretty good stories. She accepted respiratory therapists, actually inhalation therapists, we were called in those days, as accountable. Because we messed up, we fessed up. We need to delegate and show empowerment, use creativity and innovation and empathy. Empathy is not sympathy. I think if you think about how others will be impacted, that is empathy. It's not, I'm sorry for your loss. That's sympathy. And there's obviously a place for that. But being empathetic to the patient condition as they see it. I'm going home with 3 respiratory medications and a valve holding chamber. I can't pay for it. Sympathy is not the noun to use. Empathy is what we should be pursuing. Say, let me talk to your social worker and I'll see if she can come in and talk with them. Maybe there's a way that we can get those medications for you. Yes, I feel sorry that they're poor, but that doesn't get their medications. Empathy is very different in that we're thinking about how they view things. And quite honestly, at least in my experience, a number of patients don't even want to say that. So we should ask a question like, these are the medications that came about through your care here. Are you able to get them and where? We may need to lead them down that way to answer the question because they may not want to say it otherwise. Being poor is not a crime. It's certainly unhandy. And I've been there, could be there in the future. I'm sure many of us who are listening to this have had times where you're trying to squeeze those 2 nickels together. Patients that are older, on Medicare, fixed income, or very, very low income, we need to think about them in their eyes and be empathetic. If you're wondering, oh my goodness gracious, is Gary going to have 20 slides from quotes from different authors and keynote speakers? The answer is no. But I'm going to show you a couple, 3 slides to show the coalescence, the similarity, the alignment between these folks that are nationally recognized leaders and keynote speakers and others, and how that applies to us. Curiosity. Curiosity inspires us to explore what could be done for those we serve. To be given a nebulizer treatment, I wonder what would happen if I talked to the physician and said they're going home on a maintenance medication. Would it be okay, could you order, could we use the pathway, for me to start training them on their home device? And the reason I say this, physician, is that there's good studies to show that if we're giving them this nebulizer and they go home on a DPI, it works very differently. And even with an MDI with a valve holding chamber and a DPI, we inspire differently for those two. Can you imagine the physician saying, no, I can't? Humility just reminds us we need to put others first. Simply that. I have to tell you, early in my career, maybe even later in my career, if I was in charge of a project, I wanted to be in the picture. I wanted to be in the front of the line. I wanted to stand in front of that group when we got the picture, and I'm embarrassed. Leaders don't need to stand in front. In fact, if there's a team and the leader of that team is taking a picture, I would take the picture as a leader and not be in it. If you are asked to be in it, I'd stand in the back. That's humility. I, me, my are words we should not use when it comes to humility. Empathy to reinforce, listen and understand. I have a doctor's appointment next Thursday. I've never been to the office. I can't drive. I can't afford Lyft or Uber or the brand of your choice. Empathy. Let me get the social worker and see if we can find a plan. We'll get you there. We'll get you there, Sally. This was 2007. I had a look at the date myself. Institute for Professional Development, which by the way is a great organization to follow. And what this article showed, and it's just one table of the article, is people judge you based upon these 3 things. Just take a minute and look at this. Body language, most important. You can show it, you can blow it with your body language. You could be right in what you say, but not heard in how you say it, or quite frankly, how you dress. Now, the order of the day is scrubs, get it. But they shouldn't look like you slept them. I'm not saying put a crease in and iron them, but your appearance, all the affects that you have about you are the most important factor in how people judge you. Tone of voice, 38%. Doc said, you don't need those treatments. What's that tone of voice? It's uneducated, it's not in proper grammar, and it's like, I can't be bothered. Whereas tone of voice, physician Sally, glad you asked that because I assessed the patient. And what I think we should talk about is reducing their treatment frequency. And also, I'd like your permission to train them on their home device. Tone of voice, science, look Dr. Sue in the face. Spoken words, the least important. Still important, but the Institute of Professional Development said the words themselves are the least important characteristic of how you're judged. So that's what we should do. What are things we shouldn't do? Thinking you're indispensable. You're not. Can others deliver respiratory care services? Yes, they can. They're not the best. Only respiratory therapists are educated and competency tested to deliver respiratory care, but legally, others can. Talking over or at others. Man, I'm guilty in this almost every day. Listen first, talk second. Someone said years ago, the reason you got 2 ears and 1 mouth is that's the order you ought to do it. Listen first, then talk. Not delegating. And I don't mean this is only for department directors. I mean, if you have something that could be done by someone else, even more importantly, if it could be done equal or better than, why not do that? It allows you to focus on what your responsibilities are. In jargon, we use it. We've got more acronyms, abbreviations, and respiratory care than you can shake a stick at. But when you talk to non-RTs, you don't want to come up like a smart aleck, I would say, by using a whole bunch of acronyms or abbreviations, because they may see that you really know what you're talking about. You're just trying to snow them with fancy words or acronyms. Now, for the directors, this is not for the Bob and Sue working night shift, being afraid to fire people. One of the biggest mistakes in my career, people that were shown to be incompetent, I would drag my feet and continue to think, we can fix them, we can fix them, we can fix them. Some individuals need to be fired, and most individuals fire themselves. Fear and avoiding giving performance reviews. Again, mostly for team leads and managers and directors, or 360 reviews for fellow workers. One of the greatest tools that I learned many years ago was the 360 review. And I would use it as a director or service line leader. I would say to the person whose review I'm doing, I'm going to do your review in the next 45 days. What I want you to do is select 3 people, 1 from the department, 2 from outside the department, who I can send a 360 review. 360 means a holistic review. And then I'm going to pick 3 people. And they might be the same. We're not going to tell each other who they are, but we're going to get 6 reflections, 6 aspects of your performance. And then I'm going to have 1, and you're going to have 1. At the end of that, which takes a lot of time, by the way, we'll know your performance. Fear of confrontation, avoiding it, I don't like it. Fear of failing, I hate that worse. Not getting buy-in. Not getting buy-in. Individuals may nod in agreement to your face, but unless they truly buy in, they're just not going to follow through. So I think take a look at this top 10 behaviors to avoid. Turn them around. Effective leaders. Again, there's some points kind of in IMHO, in my opinion. Know when to zip it. Communication is talking and listening, and not in that order. Work relentlessly to hire the right people. Third, to get the right people on the bus and drop off the wrong people. If you're doing an interview, I like to do interviews by having a couple of staff do it, maybe the manager, myself, the director, and team, individually, not team. Again, my approach. And then we get our heads together. Sometimes we'll come back and I'll say, well, that's a great candidate. I really want to hire him. And the other people look me in the face and say, are you out of your mind? Were you talking to the same person we're talking? This person has had 3 jobs in 4 years. They just sound lazy to me. And I'm thinking, I'm just no good at this interviewing stuff. Well, the point is that may be true, sadly, but the point is any one person may be okay, may be good. You get 4 or 5 people, you're going to get the right people on the bus. Forget your title. I don't even like badges. The fact that you have 8 credentials behind your name, good for you. That doesn't mean you're an empathetic and passionate leader. Play favorites. I was told in an HR class many years ago, do not play favorites. I wrote that down, don't play favorites. Treat everybody the same. That is nonsense in my experience. Everybody is unique. Everybody can be a favorite in their way. If Sue is a fantastic therapist, and she always signs up for those vacant shifts, always said, look, I'm not on call, but if you need me, come in. I'm going to play favorites with Sue. I'm going to find a way to reward her because of what she's done for the team. And I'm not talking hourly rate, although that certainly should come up during the performance evaluation. I'm going to find a way to play favorite with Sue. Bob never ran. Gets his patient care assignments done, but doesn't call the rest of the team when he's done early after first rounds. I'll play Bob in a favorite role, which is, hey, you're doing the least amount of work. You're getting all your patient care done, but you're not a team player. So favorites, even though Bob's not my favorite, and I always use Bob for the bad therapist and Sue for the good therapist, But even though Bob is not going to lose his job, I'm not going to go overboard with Bob. I'll treat him fairly, but Sue's going to get my extra time. Give yourself a break. We just need to give ourselves a break, and really we don't do it. Now, coming down the last 3 or 4 slides, effective leaders substitute coaching for inspection. I don't know about you, but I just hate it when someone's looking over my shoulder or saying, you know, you did the report, but you had a typo. Okay, I did. I didn't spell check it or something. Coaching is very different. Coaching is individualized. It's not micromanaging. It's helping that person grow. Now, maybe Joe wants to be a night shift therapist because it works out at home, and he's no interest in being an RT navigator. That may be why Joe has never applied for an open position. That doesn't mean Joe's lazy or not interested in contributing more. He's got what he wants. Goodness knows we need night shift therapists who are passionate. So coach Joe. Don't micromanage, or don't assume that Joe is less important, less valuable, simply because he's passed up applying for a leadership position. Treat everyone differently. I mentioned that before. Somebody, hey, show me the money. Somebody else once said, look, if you can help me to have every other Thursday off, that would really work out at the house. Join the AERC. If you're an AERC member listening to this, thank you. If you're not, you need to be. I cannot imagine, and yes, I'm a past president of the AERC, I cannot imagine someone spending 2 to 4 years in school and being a professional, not being a member of their professional association. You don't see it with PTs and nurses and physicians. We need to join the AERC and actively participate to the extent that you can. You don't know everything, so ask. I had bullheaded country boys through them too much in my career. If I didn't know, I'd just keep quiet and I'd go find the answer. I learned someone knows the answer. I don't have to do the extra work, and why not learn from somebody else? It may be humbling. I'm 8th row. I said, I should have known that. Sue, thank you so much. What the heck? How come I couldn't remember that? But how does Sue feel? Hey, I'm valued. I mentioned use a team to interview and select employees, use 360 reviews, and secret shopper. I might ask you to even Google that. And we think of secret shoppers at the big box stores or high-end stores, wherever they pay people to mill around and take notes. We can do that in healthcare. In fact, I've been involved with that personally as a team in the past. Very revealing. Effective leaders get close to all your customers. Who are your customers? Your peers, physicians, leadership, patients, significant others. American Lung Association, the Senior Center, the Better Breathers Group. These are all customers, not traditional exchange customers. These are folks that we can work better with to be effective leaders. Use your team to select goals, track, report, and celebrate. And I learned from a hospital president years ago who said, we're not celebrating our failures. And again, I just coined Chuck. It's not his name. Chuck, what are you talking about? You want to celebrate failures? He said, yeah, we're pretty darn good around here, but we're not good enough. We're not as good as we could be, because when we fail, we don't celebrate that. I said, you mean like we get a couple of big cookies and some iced tea and whatever? He said, absolutely. I want you to celebrate the fact that you did something. Maybe it didn't work out, but figure it out and PDSA it, or PDCA, whichever you use, and let's do it again. We celebrated failures, and the staff were just beside themselves. Said, you really want us to, screw ups? We're going to do it. If we were trying to do the right thing and it didn't work out, let's learn from it. Hold everybody accountable. I talked about that previously. Develop a people plan along with your facility plan, your capital budget, etc. A people plan, individual, team, and department. As much as you can, laugh at yourself. I got this one nailed because of all the mistakes and gaffes I made, several that I've done through this broadcast and others that you'll hear me in the future. The more you laugh at yourself, the more believable, the more a person you are. Share the credit, shoulder the blame, and have fun. Jones Laughlin, if you're not familiar with him, one of the most passionate keynote speakers I've ever heard. He spoke at the AERC Leadership Book Club. He spoke AERC Leadership Grand Rounds. And as I'm recording this, he just finished delivering the closing plenary lecture at the AERC Summer Forum. Please Google Jones Laughlin. Here's what he does. Every day, he gets up, what needs to be done, what needs to be started, what needs to be planned, what needs to be discussed, what needs to be celebrated. I have this printed. It's when I open my paper planner every day, it's the first thing I look at. It helps me organize my day. What I have to get done today. And I need to start something today, not finish it. What do I need to be planned? What needs to be discussed? What needs to be celebrated? Again, wins or losses. The one thing I would add is what needs to be stopped. And follow Jones Laughlin. And if you'd like to add what needs to be stopped, that is how I think you should start every day, every shift, perhaps every round, perhaps every meeting in the planning of the meeting. So, again, if you want to find Mr. Laughlin, you can Google Jones Zone on YouTube and you will be delighted. So what are some guidelines? Listening like you mean it, earning loyalty and trust, emotional intelligence, IQ, not important. Living by personal conviction, driving results, being visionary, communicating the vision, mentor others, develop teams, energize the staff, build consensus, stimulate creativity. Every one of these is important. Your night shift therapist, agency therapist, faculty member, manager, director, team lead, every single one, in my experience, is important for a leader. So in closing, what about leadership development? Understand where you're at today, your skills, your knowledge, and competency. Number one, identify the gaps between where you're at and where you want to be. Again, in my world, I write this down on a piece of paper, or it could be certainly a Word document. Create the plan to get from here to there. Get a mentor. And I even say mentor someone who will sponsor you and multiple mentors. I have regular meetings with a handful of folks. We just talk about stuff. Some may think I'm their mentor. I think they're my mentor. It doesn't matter. You talk about stuff. Hey, I was thinking about this. I read this article, and this is very different from what our department is doing. So that we'll talk about actually Friday morning, and the next month when he and I get back together, we will have spent 15, 20, 30 minutes looking at this and maybe have rewritten our protocol for ventilator liberation based upon that. Two heads, better than one. Get feedback from those that tell you the real deal. Hey, how's my presentation? It's great. Oh, great. Best thing since sliced bread. What's one thing you would change? Rather than ask that question, what's one thing you would change in my presentation? And if you got two or three, I got a pencil and paper. Oh, you know that slide that had like 40 words on it? That's too many words, Gary. Can you cut it down? Yes. So as you hear this presentation, either live or on demand, I'd ask you, give me feedback on this. I really could use your help. We'll develop each other together. And I think, I didn't come up with this phrase, to develop a leader within you, start with your why. Why am I a respiratory therapist? Why am I in this position? Why did I come to choose this organization? Why did I turn that job? There must be something about my position that I like, that I didn't take that quote, quote, promotion. Start with your why every day, and I think you'll be the best leader that you can be. And with that, I'll close with, thank you for being an RT leader. Much appreciated.